All right, you beautiful nerds, welcome back to Discussions with Dr. G. It's Dr. G here, your sarcastic neighborhood nurse and part-time cat negotiator, and today we're stripping down anesthesia and pain meds to the basics you actually need. We're going to get into what anesthesia actually is, the flavor varieties out there, and a few real slices of life from the bedside. So let's crack this open together, shall we? Anesthesia isn't just about knocking people out. It's the magic sauce that lets us do things to patients that they'd never willingly sign up to if they were wide awake. Think open heart surgery, C-sections, or heck, yanking a tooth that's been screaming at you for a week. There's a whole buffet of anesthetic approaches, and nurses really do get a front row seat. So here's the menu. You've got general anesthesia. This is when we turn off the consciousness, basically hitting pause, and the patient needs their airway fully supported. Folks are completely out, no remembering, no awareness. Then there's regional anesthesia. Think spinal, epidural, or nerve blocks. The patient can breathe on their own, thank goodness, and you've got numbness in just one region of the body. And if you've ever been numbed up for dental work or had stitches, that's local anesthesia. Super targeted numbing, either injected or applied to the skin while the patient is very much awake. Maybe too awake sometimes, depending on your dentist's playlist. I gotta tell you though, the nurse is pretty much the thread holding this whole production together, from prepping the patient in pre-op to catching the vomit in PACU, to helping manage chronic pain down the line. Quick story before we roll on. I once had a patient, first baby, first epidural, and she was shaking like a chihuahua at the vet's office. My job wasn't just starting the IV or making sure paperwork was done. It was walking her through the whole thing, calming her down, teaching her to breathe, even holding her hand while anesthesia worked their magic. That's the kind of stuff you don't see on TV, but it's the real heart and guts of nursing when it comes to anesthesia. Now, let's untangle all the drugs floating around the OR, because trust me, there are a lot, and each one comes with its own quirks and booby traps. So, you've got sedative hypnotics. Your classic is propofol, which honestly looks like milk and works crazy fast. Propofol and its cousins like ketamine or etomidate basically crank up the GABA, or in the case of ketamine, block NMDA, hitting pause on your brain, which, let's be honest, sometimes we wish could happen outside surgery, right? Oh, and ketamine? Ketamine is that weirdo that's great for pain, doesn't drop your blood pressure, but yeah, it can make you hallucinate purple elephants. But in the OR, it can make blood pressure and heart rate shoot up, or even give you those weird trippy dreams. Next, our opioid crew, fentanyl, remifentanil, those NIL meds. They're the powerhouse painkillers, but holy moly, if you overshoot the dose, your patient isn't just sleepy, they might stop breathing. That's not even getting into the nightmare of the chest wall rigidity, where someone's lungs are screaming to breathe, but the muscles just say no. First time I saw it, I thought the patient was just tensing up, and my preceptor leaned in and said, "Yeah, we call that fentanyl's party trick." Brutal. Benzos. Midazolam is the big player here. Amnesia, anxiolysis, the whole deal. If you mess up, though, you're back into the respiratory depression doghouse again, and the only way out is that rescue agent, flumazenil. I'll do a quick shout out to neuromuscular blockers like succinylcholine. It paralyzes every single muscle, but here's the kicker. It can cause a life-threatening reaction called malignant hyperthermia. I saw a simulation mock code thingy once where we had to spot muscle rigidity crazy fast or things could have gone bad. Whew! Being quick on your feet makes all the difference. And then we have inhaled agents like sevoflurane, isoflurane, or nitrous oxide. Those are the old school but still good for induction and maintenance. Just don't forget that they carry their own risks, including, you guessed it, malignant hyperthermia and hypotension. Finally, our local anesthetics like lidocaine, the BFF to every nurse. They just block sodium channels, stopping that nerve depolarization. Too much though, and you can end up with arrhythmias or seizures. Locals are safer in small doses, but when they get into the bloodstream is where those seizures and wacky heart rhythms can start. The gist? These meds are powerful, but a combo platter. Multimodal approaches means you've got to stay sharp and watch for stacking effects, especially sleepy breathing disasters. And as a nurse, you're the safety net watching for reactions, double checking doses, and never ever turning your back on a patient who's freshly medicated. Trust me, the safest med is respect for what these drugs can do and hawk-like vigilance at the bedside. All right, so when do we actually need anesthesia? Surgeries, all sorts of invasive procedures. Think endoscopies or labor pain or even chronic pain intervention. There's a long list of reasons, honestly. If anyone wants to volunteer to have their appendix out with no drugs, just kidding, I don't recommend it. On the flip side, not everyone is a candidate. You got to look out for folks with serious allergies or hypersensitivity reactions. Trust me, the I'm allergic to everything is not a starting point for propofol. Malignant hyperthermia is the big ugly here, okay? Especially with succinylcholine or those inhaled agents. If you see it in the chart, avoid those meds like the plague. There's also severe liver and kidney issues. If the drug isn't getting cleared, guess what? It just hangs out. Also, some agents might spike BP like ketamine or drop it like propofol. This makes med selection a bit of a puzzle. You know what I've learned? The best nurses are the ones who ask, wait, does this make sense for this patient? If something feels off, like a weird set of symptoms, or the patient swears they've never had anesthesia before, but has a story that seems vaguely familiar, just pause and advocate, okay? Sometimes it's allergy confusion. Sometimes it's the, oh, I forgot to mention my cousin reacted badly to anesthesia once chat. And sometimes it's something way more serious. Nurses really do spot the stuff others miss, okay? All right, you have made it to the finish line, so let's talk about day-to-day reality for nurses around anesthesia and pain meds. First, and I can't stress this enough, you're not just taking vital signs because it looks good on the chart, okay? We're talking relentless monitoring, heart rate, blood pressure, oxygen, neuro checks, even urine output if you want to do the full nerd thing. If a patient's breathing slows to a crawl or they get that weird muscle rigid look, that's time for action and not a coffee break. My first time teaching Pharm, the students came up with some hilarious acronyms for anesthesia complications. My all-time favorite was Mr. Hot. MRHOT. Ready? Malignant hyperthermia, muscle rigidity, hyperthermia, O2 sat drops, tachycardia. No, it's not in your textbook, but hey, you'll remember that you laughed at that, Mr. Hot. Anyway, watching for cues is key. You see mental status changes, sluggish breathing, drop in O2, that's your detective hat. Analyze, make a move, support that airway, call anesthesia, give the reversal if it's ordered. Never let someone walk out of the hospital without the basics. You know, don't drive after sedation, let them know that the nausea, sore throat, sleepiness, all of that is going to happen and it's expected. But here's the big one. Always ask about the natural stuff, okay? Ask them about their herbal medications. Do they use marijuana? Do they use CBD? Whatever TikTok couldn't keep quiet about this, this week. I once had a patient ready for surgery who, thank goodness, blurted out something about St. John's wort during my checklist. Saved her from a pretty gnarly drug interaction. Anyway, let's lay it all out for patients, okay? Report muscle pain, anything weird, confusion, keep those pain meds under lock and key at home. Keep them safe, keep them smart. All right, as promised, I kept it real, and that's all I can do for you. Anesthesia is complicated. No shame in checking your facts, and there's always something new to learn. So next time, we will peel back another layer of the pharmacology onion, maybe even chronic pain, maybe something you can vote on for. But anyway, just go ahead, go wash your hands, hug your cat, respect reversal agents, and I'll catch you next time.